So there are a lot of consequences. It's better to address the topic. And after that, when you address the topic, mostly we will know a lot of solutions because we know much more than the patient. We have the helicopter view, we see what they are doing, we can give sometimes very simple advice which they didn't think about because they are locked into their relationship. It's, for instance, very funny, they say, I'm so tired in the evening. And then you say, did you ever try to have sex early morning? And then they look at, why didn't we get this ID? They look at each other. We simply can give that ID. And another good thing, in the morning, your testosterone, both in men and in women, is higher. So it's a good advice to do that. If you really don't know what to do, then you have to send to a sexologist. And you have some here in Iceland, not yet many, so I think it's wise if in the near future you build up more people to do this, doctors and psychologists and social workers who are very good in dealing with all those problems in sexuality. Nowadays we have a new medical specialization which is called sexual medicine. I'll show you some of the things, what I call the toolbox of sexology, clarity in the male-female problems, restructuring roles and patterns, dealing with fatigue, dealing with pain, dealing with stoma and incontinence, renegotiating intimacy, dealing with loss and mourning, development of new erogenic zones. If, for instance, you've got a spinal cord injury and down there you don't feel anything, you can learn to get new erogenic zones in other sides of your body. Teaching on tools and toys, vibrators and that kind of stuff. Continence management, side effects of medication. We know very well how to deal with the SSRI side effects, hormonal deficiencies, partner relation therapy, lubricants, etc., etc., etc. We have a lot. The toolbox is very full. We are the fastest growing specialization in medicine presently. And this is what you see for doctors. There is a group of doctors where now they get even, you can become fellow in the European Committee of Sexual Medicine, which is a European specialist organization endorsed fellowship. Good, and a book you have here in the hospital now. Thank you. Questions?
Well, thank you very much, Woet, for a very informative and enlightening lecture. And now we'd like to have some questions. There must be some. Sunna.
I have a couple. Hi. My name is Sunna. I work with dialysis patients, amongst others. I enjoyed the lecture very much. Thank you. Concerning the testosterone deficiency in male dialysis patients, I think we are becoming more aware of this problem now. It's only because of sexual problems, but also because of increased mortality, low testosterone, and so on. Are there any guidelines as to what you should aim for? Because if you take the testosterone, if you measure it in these patients, who suffer in the lower range or just below what is considered normal, is there any ways to know what to aim for with therapy?
I don't know by head. I have to look in my papers what are the levels. But I can send you, if you send me a mail, I can send you the presentation I have given at the exam course for the European Society of Sexual Medicine on dealing with that, because I'm not a urologist or andrologist, so I was much more in female sexuality than in male sexuality. But they have below a given, I think it's 6, below 6, then you have to add, and if it's above 12 you need not to add, and in between you can discuss with the patient, somewhere like that.
Pretty close in terms of our units here.
Yeah, but that is, even for some men, when they are low, that doesn't mean that it's abnormal. And for some men, if they are in the normal range, doesn't mean that it's normal. Because if you have been always on a high level, and then through disease you get to a low level, then sometimes you can be helped very much by adding a little bit. And there is no risk in giving testosterone in people with a kidney disease. If you have prostate cancer, of course you shouldn't do. But in a kidney patient, no reason not to give it. You are dealing with the dialysis patients. You have the fantastic position that you regularly have 3, 4, 5, 6 patients, and you can give so nice sexuality education to the group of people. No other group can do this. You can do that.
Except they all lie in the same room.
Yes, that's
Group sex?
that's group education. It's not group sex, it's group sexuality education. But I did a lot of sexuality education in my rehab center, and it's because if you address a group, you can say what happens in one man or in another couple without addressing specifically this man or this woman. If you address the group, you can give a lot of education in a marvelous way. Why not use the time? And probably they will be extremely interested in it.
There's something called the kidney school, and she knows all about it, Hluti. This could be one of the components to be added to the school.
Yes, yes.
Mm-hmm.
I have actually another question also concerning the ovarian cancer patients. You said the 50% of the testosterone comes in the women, comes
Yeah.
from the ovaries, and then 50% from the adrenal glands. If you cut away the ovaries, the adrenal glands don't overstimulate, so they...
No, no. It's because it's a different system. It's what you get from the ovaries. They have the feedback loop from the pituitary gland. The adrenal glands, they make it by themselves, and they are not reacting on the amount which is made by the ovaries. Sorry. So they have their own level. But sometimes you get into problems if you get trouble in your pituitary gland. My last patient, I've seen her, I think 10 days ago. She had an accident on the ice. She slipped and she fell on the ice with her head very seriously. And after that, her eyes looked like that. And now she has lost her sexual desire. She has lost her orgasm capacity. And the neurologist never looked into the hormones. So she went with the sexual problem. She came to us, to the rehab center. And it's very clear that her pituitary gland has been damaged by the fall. And now she doesn't make sufficient LH and FSH. And that's the reason that she's now into sexual problems. So it's fantastic, complex, but very interesting.
How would you treat that? I mean, if there's a problem with the testosterone deficiency, and you would have to add it.
Add it,
sure.
yeah.
But the way I see it, it could be tricky because you don't want to give too much.
No, but that's the problem. You know, we all, as nearly all gynecologists in the Netherlands, they are very scared to give testosterone. Because they say, if you give testosterone, you get a moustache.
Right.
But look, the women here, they don't have a moustache because they have their lower level. Now,
if... It's regulated, though, in the normal person.
Yes, but if you go back into this normal level, and that's what you can do with proper treatment, you don't give, okay, 3 tablets, no, you give and you phone after 2 weeks, and then you increase and then you phone after 2 weeks till they are at the level. And the level of the testosterone is how they feel sexual. And that is their original level. And for some of them, the level is higher, for others, the level is lower. But it's the clinical picture. That means you need a sensitivity in the connection with the patient. But you can do that. But it's, of course, we are always scared because we all know the stories of the transsexuals. But that's very different because when you add testosterone to a woman who doesn't have enough, or you give testosterone to a female body who wants to be a male, if you give that, you give a big shot and you are shocked what happens. Within 2 weeks, you get a complete different person who's smelling under the armpits, who's rough, who's distant, who's horny like hell. But that's what such a big amount does. That's the difference between male and female. Other questions?
Other questions?
I had a question regarding the SSRI-induced sexual side effects. You mentioned some tricks like dose switching. I'm a psychiatrist, by the way. What about the antidotes? Have you any experience with that? I know some are using bupropion or buspirone.
Bupropion, amantadine, antiserotonergic medication, even Ritalin. If it's only a problem for getting orgasm, you can use sometimes Ritalin. So it depends a little bit. Mostly it is to deal with orgasm. But the other thing is, if you have, for instance, paroxetine, who has a short half-life, then what you can do is stop the medication for 2 days, 2.5 days, and then the antidepressant effect will not change, or the anxiolytic effect, but the sexual side effect will go down very quickly. It's the same the other way around. When you start an SSRI, then it takes 4 or 6, even up to 12 weeks before it acts. But we use the same SSRI for premature ejaculation, and we tell it, take it 4 hours before. After 4 hours, it works already. It's the same going up and going down. So you can do this weekend pause, but you cannot do that with Prozac, because Prozac has too long half-life. Yeah. That's a trick which we use regularly.
More questions?
I'm
Comments?
thinking about the testosterone, the different ways to give testosterone, because you can have the gels applying every day, you can have shots in 10 weeks intervals. What would you prefer, like in, again, dialysis?
I prefer that what I am used to. So you have to ask the doctor who's doing that regularly, the andrologist or urologist, and ask him, can you tell me, and then you start that treatment and do that regularly. Don't switch from one to the other. So I was dealing mainly with female with low testosterone, and I had my own tricks with methyl testosterone because there were no, how do you call it, plasters at that time. And nowadays you have the plaster, the intrinsa, but you have also the gel. So nowadays we have to do it with a very low amount of gel, of what, like the testim gel, which we give to the male. We give them now to the female, but then in a very low amount with a tuberculin syringe, just to put it on the skin. No, not here, on your belly, low on your belly.
Now, clearly there are numerous things we can do in our practice, but I'm still thinking about this barrier that we have, obviously, between
Yes.
the patients and the professionals. And just one thing I was wondering about, because Jona mentioned the kidney school that we have. When we supply, when you have somebody who has a serious chronic disease, it's going to be a long-term battle, and we would like to address issues that we can do for them, giving them information packets, for instance. Do you think it would be wise to have, to include?
I think it's very important to give information, because information which you can read at home, you can read with your partner, it helps a lot. But there's one very good thing. If you tell to your patient, if you open up the discussion on sexuality and say, up till now we didn't discuss it, but we know that a lot of patients, they have troubles with sexuality. It may be good to address it. If you do that, you get a better connection with the patient. And by getting a better connection, you get also more compliance. That's the fantastic thing. Patients listen better to you. Relation is better, compliance is better. And the next bonus is that I believe that all those people who regularly talk sex with their patients, that your own sex life improves as well. Because you are going more to understand about what's going on in people. Right. Because we all have, from ourselves, we have kind of insecurity. Don't I do it too much? Is it enough, etc.? Is it not strange what I'm thinking? When you regularly talk to patients, okay, I'm normal.
Right. But again, I'm thinking more about this sort of general information that we might provide to people, before having this contact with them. And do you think it would be, because you mentioned that there's a subset of people that might not be open to this. Do you think it might be, for instance,
if they are not open to it, doesn't matter.
Them if they get a package from us, and here you have, a lot of, information about sex and sexuality.
Yeah. The funny thing is, because we have done that in the rehab center with extensive training, that the majority of patients, the majority of professionals are scared to address it. Oh my God, what will they think about me, etc. That kind of thing. And what are they going to do if I ask that question? And then in our training scheme, they were obliged to talk with their patients. And then they came back after 3 weeks and said, patients, they are so happy with it. Well, I don't understand. I've never realized that it's so easy. And even that patient sometimes said, finally, they asked me this. I've already for 3 years a problem. It's so funny.
That's right.
So, but I think especially in the groups, when you give any kind of group education, if you have bigger group of patients like dialysis, kidney or cancer, and you regularly have groups of people together, invite somebody from, like Jona, to talk about sexuality, or do it yourself, or do it together, and it gives so much building up of openness.
Very good. We'll have that as the final word today. Yeah. Thank you for coming. And
okay.
Thank you very much again. Thank you very much.